I'm never gonna learn this game.
What's up, folks? Happy Friday. We're very, very excited to have you for yet another RLR. As always, we have to show gratitude and love to the people who make this happen. And today, in the scribing role, is none other than VJ. VJ, I'll hand the mic to you if you're able to unmute and say a quick hello. Tell us where you are, what you've been up to.
Hello everyone, I'm Vijay, a pulmonary critical care resident from India. Uh, Happy to be scribing today for an exciting case.
Amazing. I think VJ, it's just so telling that you are so far along in your career and yet are humble enough to keep doing the scribing of the core essence of what we do. I'm very, very grateful for it. Prof. Rez, you and I should scribe too someday and learn from some VJ, you know? I think that'll be key. Prof. Rez is like, yeah, smiling, but no chance. I'm not do that. In the teaching points role, there was a battle today, an argument in the WhatsApp channel from Tashiar and Anmol. I don't know the outcome of said battles, so I will ask each of you to unmute and say hi. Maybe we'll do it alphabetically, starting with Anmol.
I think Kasha, I will be doing the teaching
I
points because
see you lost the battle. You won yesterday against the case, so it's only okay if you lose. Only if you lose today. Awesome, Khashar, please say hi.
Hi everyone, I'm Hashar, a medical student from Iran. I'll be doing the teaching points today.
Amazing, Khashar, so nice. I feel like this is your regular gig now, Friday teaching points, which I love. I will now pass the mic to our case presenter. Very, very grateful for Alec for all the things he does in CP Solvers, including actually just an incredible reflection on hyperkalemia that he just posted in the Academy chat. But we'll hand the mic to you to say hello, and really grateful for you jumping in last minute to present a case.
Pleasure is all mine. Always happy to be here and learn from everyone. Hope everyone's having a great day, no matter what time it is and no matter where you are. And I have two cases. I have rash and I have dyspnea. Which one would you guys like today?
Prof. Rez, it's only appropriate that you choose. I'm just honored to have the choice.
Alec, I want to say it's dealer's choice. Whatever you're feeling, my friend. I'm feeling generous today. You know, I lost this game of golf. I can't make decisions anymore.
Well, Reza, if you want to feel better, you can play golf with me because I'm sure you'd take my money. Yeah, I think I'll go with the dyspnea case. And I guess if we get the whiteboard, I'm happy to start whenever.
And who knows, maybe if we finish early, Alec, you can just show us a picture of the rash and we can try to tackle that real quickly.
Okay, this case has a lot of aliquot, so I'm not sure we'll finish early, but I'll do my best. All right, so today we have a 47-year-old woman presenting with dyspnea and exertional fatigue. So just to give you a little bit of a background, she says for about 3 weeks, she's had some progressive dizziness, some dyspnea on exertion and fatigue. She's also had some pain in her ankles and her hands, but no swelling or redness. And over the last 6 months, she also reports amenorrhea, weight gain of about 20 pounds, some constipation, and some hair loss and thinning. And she's never had anything like this before. She hasn't had any fevers, any chills, any chest pain, cough, no headache or visual changes, no GI symptoms, no nausea, vomiting, no rashes, no leg swelling. But she does report chronic bilateral knee pain, which hasn't really changed very much. And these symptoms, she sort of just dealt with them, but they got to the point where she wasn't able to work anymore. So she decided to come into the hospital. And that's the end of aliquot 1.
Wow, I am so excited to discuss this aliquot because we have a few symptoms that we don't often think about, like alopecia and constipation. What I'll do is I'm actually going to just focus on the other symptoms and then ask Robbie to tie that in with the dyspnea in a way that might make sense. You know, the interesting thing with alopecia is that most often it's due to androgen excess, testosterone excess. If you look at myself and half the population past a certain age, they have DHT sensitive hair cells that end up falling out. And the reason it's sort of in this horseshoe pattern is because the hairs on the back of the head are resistant to this DHT. So anytime you have alopecia in men or women, you have to ask the question, what's going on with the androgen or testosterone? In women too. And in women, when you take that approach, all of a sudden, a diagnosis that comes to mind is polycystic ovarian syndrome. And these individuals end up having some obesity, acne, hirsutism from the testosterone, but hair loss in the areas where the hair follicles are actually sensitive to it. And you had mentioned that she now has amenorrhea. She is 47, so it'd be important to know what her menstrual cycles have been, because she's at that age where she might be approaching menopause, and this is just a prelim signal to the approach of menopause. So beyond androgen and testosterone excess, when you have hair loss, you can think of conditions like hypothyroidism. There's endocrinopathies. Now that hair loss may be in the eyebrows, it may be in the scalp. And the fact that she has some joint pain and some constipation, something worth considering. And I know we haven't framed the problem yet, but I have to throw out these diagnoses and I'll be tracking them as this case unfolds. And Alec, I actually have to mention one more thing with hair loss. It's good to actually characterize the hair loss. Is it diffuse? Is it in a single location? Because we know that there are autoimmune diseases where you can have hair loss in a specific location and then the hair regrows, and it's not related to testosterone, it's not related to stress, it's not related to an endocrinopathy. It's alopecia areata. So the pattern of hair loss on physical exam will help clue us in to what diagnoses we're considering. And then of course with like lupus, you know, you can have like scarring and that can lead to particular hair loss. So I think the physical exam will be helpful for the hair loss, but if I were to just summarize my approach to alopecia, I think first characterizing, is it like diffuse thinning? Is it just on the scalp? Or is it a specific location? And then just applying the base rate and saying, hey, testosterone in men and women is going to be the primary cause of hair loss. And then thinking of those conditions in women, specifically polycystic ovarian syndrome. Now with constipation, constipation is not uncommon, and we all have experienced it in one form or another. The question is, when should we get concerned? Like, when should there be a reason for us to actually dive into constipation? I would say, and I learned this from Robbie, and he has a terrific figure that I encourage you guys to go look up on Clinical Problem Solvers. If that constipation is the sudden onset, it's brand new, if it's refractory to treatment, if it's associated with any other red flags, then you should be concerned. For example, weakness, urinary, any other neurologic symptoms. Since this seems like it's a new concern and there's all these other associated symptoms, it's worth thinking about secondary causes of constipation. And it's so easy to see how that constipation may not even be brought to the foreground from the patient, because there's dyspnea, there's amenorrhea, there's hair loss, there's joint pain. But for the secondary causes, the first thing that Robbie will roll out in the ED is obstruction. Is this pseudo-obstruction or obstruction? And then the other low-hanging fruits include stuff like electrolyte abnormalities, hypokalemia, hypercalcemia. It's really hard to diagnose those until you get the labs, but I'll be looking at those electrolytes. Is she on opiates? Is she on iron pills? The other common causes of constipation. Then there's less common neurologic causes of constipation, from autonomic issues related to amyloid, for example, to actually issues at the spinal cord where the bowel is controlled from those parasympathetic nerves from the sacral, lumbosacral plexus. And so if you have any lesions there, they can also lead to constipation. And then worldwide, Chagas, etc. I'm being very broad here, Robbie, and I know it's not as related to this patient, just because I don't think about these concerns often, and I just want to challenge myself. So I'm going to pass the mic to you in just one more minute, because I think the other thing is like these joint pains. You know, if I were to look at all of this stuff, I would say, man, alopecia is so rare. So probably the diagnosis, if it's not a common cause like testosterone excess, is probably going to be explaining the alopecia. And with the hand pain, although we don't have swelling or redness, we can still have synovitis. So the exam is going to be important. If it is synovitis, then we can start applying Kara's beautiful schema. Is it symmetric? Are we saying there is inflammation? And then going down the route of, is it an RA-like phenomenon, or is it a lupus-like phenomenon? But I'm gonna leave it at that. Robbie, I didn't touch base on the amenorrhea, but I would love for you, even if you, in addition to this, just touching a little bit based on how you think about amenorrhea as a VA doctor who never sees it come in.
Oh my gosh, Prof. Rez, I think you've earned your $60 back from your dad just with that aliquot alone, if not more. And yeah, you know, I think the shortness of breath is really intriguing here. And I think we've talked many ways about how to analyze and slice shortness of breath, but realistically speaking, the accompanying symptoms often help significantly. So if I take care of a patient who checks in and says, hey, I'm short of breath and I have a fever, I immediately know that the probability of a pulmonary focus of infection is very likely. So fever and shortness of breath is pneumonia until proven otherwise. The other very powerful clue is when the patient is puffy, i.e. swollen and shortness of breath, where you can hurdle towards the diagnosis of heart failure. And here, that's the case, right? The patient has had shortness of breath for 3 weeks and has gained 20 pounds. And so you immediately start to hurdle towards the diagnosis that this is water weight. And that meets tremendous resistance when you realize that the patient doesn't describe any swelling. And of course, there's a caveat there. The patient may not perceive swelling that then you pick up. But I want to just clarify that that little mind warp that happens. I tell you, you have a 47-year-old person who comes in with shortness of breath for 3 weeks and has 20-pound weight gain. You're like, this is heart failure. But it's probably not, based on the fact that it seems that all this weight is not fluid. And so I think what you probably would do in shortness of breath here is then you'd be like, wait, hold on. This is a very odd scenario. What brings in shortness of breath and weight gain simultaneously that isn't heart failure? Real life would kick in there and tell you, I would bet that deconditioning is the most common cause of patients who gain weight for other reasons, then notice shortness of breath. And I've seen that over and over and over again. Of course, you want to stop and make sure there isn't something real, but I think that would be the most likely scenario. So this is one of the very few circumstances where I think, because of the tremendous pull of all the other symptoms, I, for the first time ever, ever on VMR, I'm open to the possibility that the shortness of breath here is a distractor. And really, the only time that shortness of breath is a distractor is when it is extrathoracic, like it is with anemia or acidosis or deconditioning, where the problem lives elsewhere. Otherwise, it usually lives in the heart and the lungs. So that's the progress that I've made with shortness of breath, is I'm going to evaluate it with the same ferocity and intensity that I would anywhere who's short of breath. But I'm already from the get-go open to the idea that the problem may live elsewhere. So where else might it live? I think the amenorrhea is potentially a clue, but the exact same calculus applies to the amenorrhea as well. When we break down amenorrhea, we know that the patient is no longer having vaginal bleeding. And in somebody who's had vaginal bleeding before, this would be called secondary amenorrhea. That distinction allows you to reduce the probability of an obstructive structural cause that has been present lifelong, and also reduces the probability that the patient has a fixed disturbance in her gonadal axis, i.e. one acquired from birth, like ovarian agenesis or premature ovarian failure or primary ovarian failure. So I would be systematic here and say that amenorrhea is likely, this is secondary amenorrhea, and secondary amenorrhea reflects either a deficiency in estrogen or a deficiency in progesterone. Is unlikely to be related to any structural lesions here. The deficiency of estrogen is further broken down into hypothalamic and pituitary dysfunction or ovarian dysfunction. Ovarian dysfunction is exceedingly rare, and hypothalamic lesions, either structural or otherwise, are more common. That is deficiency of estrogen. Deficiency of estrogen is much less common than deficiency of progesterone. Progesterone deficiency is typically the result of excessive androgens, either mildly in the form of polycystic ovarian syndrome, or more overtly in the form of Cushing's syndrome, adrenal carcinoma, exogenous testosterone, so on and so forth. How would amenorrhea be useful here? In the context of weight gain, amenorrhea is often related to a deficiency in progesterone as a result of the excessive action of androgens and other similar hormones. So my leading suspicion with here, to sort of summarize, amenorrhea is either a hormone issue or a structural issue. A hormone issue can be further broken down into an estrogen issue or a progesterone issue. Estrogen is on the gonadal axis. Progesterone often reflects excessive androgenic activity. How would you make progress in real life? You would measure the hormones that we just talked about, and others as well. Practically speaking, you'd probably measure beta-HCG, prolactin, TSH, and other pituitary hormones. But one helpful strategy is to prescribe progesterone and see if the patient has a withdrawal bleed, i.e., you diagnose a progesterone deficiency by seeing if the patient subsequently has vaginal bleeding with the administration of progesterone. So to summarize, Prof. Rez, I think the shortness of breath should be evaluated the way we've talked about it many times. But I think early on, being open to the possibility that it reflects deconditioning from the weight gain. I think the weight gain is central to this case because it seems to be solid weight gain, not liquid, and might explain the amenorrhea through excessive progesterone, but it also might explain the amenorrhea simply because of hypogonadotropic hypogonadism from the patient not feeling well and having a serious medical concern. And so a lot of work to be done. I'm really, really excited for the next aliquot, Alec. And there's no way we're getting this rash. I understand why now.
Amazing discussion as always. So I'll fill out the southwest corner and give you an exam as well. So for the past medical history, the patient has atrophic gastritis associated with B12 and iron deficiency and osteoarthritis of the bilateral knees, but she hasn't seen a doctor for the last 5 years or so. She has no surgical history. In regards to medications, she takes acetaminophen as needed, but hasn't taken any B12 or iron supplementation for at least 2 years. She is unaware of any family history as she was adopted. In regards to social history, she smokes 1 pack of cigarettes every 1 or 2 weeks, has occasional alcohol use, no illicit drug use. She works as a cook at a fast food restaurant. She's originally from El Salvador, but she has lived in the US, all in Texas for the last 10 years or so. And she lives with her husband, has no children, but prior to all this starting was having fairly regular periods. This isn't like something that has been common for her. In regards to the physical exam, on exam, she was afebrile, heart rate was 63. Blood pressure was 111/62. Respiratory rate was 18, sitting 98% on room air. And the patient's BMI was 42. On appearance, she's awake, alert. She wasn't in any distress. Her face kind of appeared roundish and full compared to prior pictures. I actually had her take out her ID to look at it. On HEENT exam, atraumatic oropharynx was clear, mucous membranes were moist. There was some conjunctival and sublingual pallor. On neck exam, no lymphadenopathy. There was enlargement of the dorsal fat pad. In regards to the cardiac and pulmonary exam, both were unremarkable, including no appreciable JVD. The abdominal exam was also soft, non-distended, no rigidity, no rebound or guarding. And when it comes to her extremities, there was no erythema, warmth, no tenderness, no synovitis of the feet, ankles, or knees. There wasn't any clubbing. There was no edema. Pulses were 2+, posterior tibial bilaterally. In regards to her neurologic exam, fully oriented, moving all extremities, sensation was grossly intact throughout. There were no documented visual field abnormalities. And then in regards to her skin, there were some stretch marks on the bilateral abdomen with faint reddish purplish discoloration, but really not that remarkable. And then her hair was just diffusely thin. There weren't patches that were out of proportion to others. There were just less hair than she had before. And I'll post this in the chat as well. So this will all be there, but that's the end of this outline.
This is super helpful, Alec. And maybe I'll just leave the exam for Prof. Rez to analyze because it's super rich. And I'll tell you that the background medical histories, I think, doesn't sway me too much. I think the history of atrophic gastritis is something to latch onto if the syndrome were compatible with a endocrine deficiency. And I don't get that vibe from the rest of the case. Because what atrophic gastritis could mean is it could be part of pernicious anemia, and pernicious anemia often results in can result in other endocrine issues, but other endocrine issues are often loss of endocrine function, like hypopigmentation from vitiligo as an example. And so I think that what's really important to track from the background history is the possibility of something heritable when you don't know the family history. And also to remember that patients who are born not in the United States don't just have conditions that may be transmitted, don't just have infectious diseases that relate back to their origin. There are a variety of things that can be carried over from a previous existence in a different geographic location. And we've talked about some of them, and I think that may or may not be relevant in the future. But I would just remember that like that the only reason to latch onto that history is not to try to bring in any infections, but for example, cultural norms, behavior patterns, malignancy risk profile. For example, just to give you a concrete example of malignancy profile, patients who've immigrated to the United States from parts of Central America continue to have a dramatically increased risk of gastric cancer as an example of that concept. And so put a pin in that. I don't think this case is screaming infection, but that doesn't mean that her origins tracking to El Salvador have no relevance to this case. We'll see if they pan out later. But Prof. Rez, what are you thinking about this exam?
Wow, I am extremely excited to tackle this exam because oftentimes a physical exam is not good at ruling anything out, but it's terrific at increasing the probability of a specific diagnosis or a particular bucket of diagnostic consideration. And what we see here, which I think is really important, Rob, because you said in aliquot 1, you don't think that the shortness of breath is the center of gravity. And I think here the heart and the lung exam support that initial hypothesis. There's no crackles, there's no murmur, there's no jugular venous distension. I think it was very smart of Alec to compare her facial appearance now to prior, because really the exam that Alec gave us is strongly supportive of excess cortisol, of Cushing's. Why? Because we have the moon facies, we have increased the fat pad, and then we have these stria. And now if we look at that HPI and we say, hey, this is someone with weight gain, hair loss, amenorrhea, it's very consistent with the diagnosis of Cushing syndrome. Now, what's really intriguing to me is going to be what the labs show, because once you are worried about hypercortisolism, the question becomes, is it due? The easy way to approach this is really think of two buckets, okay? One is someone that's taking steroids exogenously. It's really important to consider this bucket because steroids are prescribed all the time for various conditions in medicine. Or is this something due to endogenous hypercortisolism? And in order to tackle that, you just have to think about the hypothalamic, pituitary, adrenal axis. The hypothalamus stimulates the anterior pituitary to release ACTH. So you have CRH from the hypothalamus, ACTH from the anterior pituitary, which then acts on the adrenal cortex ACTH acts on the adrenal cortex to stimulate endogenous glucocorticoids, endogenous cortisol. And so the question then becomes, where is the lesion along this pathway? And Alec went ahead and did us a favor too, and he gave us the visual field exams, because again, this doesn't rule out that there isn't a pituitary cause of possible Cushing's, because that by far is going to be the most common cause of Cushing syndrome. But if someone had a pituitary adenoma that was impinging on the optic chiasm, then you would have bitemporal hemianopsia. So, Robbie, I think we're going to have a lot of time to discuss hypercortisolism more, but I just want to leave it at that this exam to me, moon facies, increased fat pad, with the hair loss, with the amenorrhea, with the striae, because you're getting the striae, you're getting stretch of that skin. You know, people who exercise a lot get stretch marks, but people with Cushing's, due to the stretch of the skin, you get those vessels stretch and you get that purple mark. So right now, I think what the exercise is, let's look at the labs. Let's see if there's any metabolic derangements that may prioritize ectopic Cushing, which is far less common than Cushing syndrome, where you have a pituitary adenoma that just releases a lot of ACTH. And I think in this patient, right off the bat, I will be sending those laboratory markers of ACTH, of TSH, of LH, of FSH, of prolactin. I think it's important to send the entire access. And then we go from there. I'll be looking at the potassium, I'll be looking at the bicarbonate. But right now, I just think we have Cushing syndrome. Thoughts on that, Robbie?
Thoughts on that? You earned another $60. Congratulations. You're you're getting rich with this case, Prof. Rez. That was awesome. I completely agree with you. I think that's the tension in this case, and I think we need that. We're probably confident that this is the problem space, and now we'd have to try to figure out which of the underlying categories are likely at play here. Well, all right, Alex.
Amazing. Absolutely amazing discussion. So let's get to the CBC. So it showed a white blood cell count of 7.4. 71% of those were neutrophils, 0% eosinophils. The hemoglobin was 5. Normal in our lab is 12 to 16. We don't have any recent baseline. The MCV was 68. And the platelets were 523. Upper limit of normal for our lab is 400. In regards to the CMP, it was all within normal limits for specific labs. The sodium was 140, the potassium was 4.5, the chloride was 107, the CO2 was 22, the BUN was 16, the creatinine was 0.7, the glucose was 101, and the calcium was 9. And the liver chemistry test, including the albumin, were all within normal limits. And we got a urinalysis, did not have any proteinuria, hematuria, or pyuria. The urine pregnancy test was negative. EKG was just normal sinus rhythm. Troponin was negative. Not sure why it was checked. But the chest x-ray did not show any acute cardiopulmonary abnormality. The BNP was 58, normal being less than 100 in our lab. The HIV and HIV was negative. The lipids were normal. And A1C was, hemoglobin A1C was 5.1. She had x-rays done of the hips and ankles and hands. The bilateral knees showed some mild osteoarthritis, but the imaging elsewhere was normal. And then for some additional work of her anemia, her ferritin was 12. The iron saturation was 2%. The vitamin B12 was less than 100. Folic acid was normal. And the LDH and haptoglobin were both normal as well. The reticulocyte index was less than 2. The smear was without schistocytes, spherocytes, or really any other remarkable findings. And all the coags were within normal limits. And I think that's where I'll stop for this aliquot.
Yeah, I think a very, very interesting aliquot, Alec. You know, the first thing that jumps out to us is that, oh wait, Prof. Rez, you're up. Sorry, I completely forgot. No, go for it. Go for it.
What I'd like to do is give Ravi a chance to talk about this aliquot.
Yeah, well, Prof. Rez, I was like, oh, look at that microcytic anemia and thrombocytosis. That's the characteristic feature of iron deficiency. And I was wondering if we were going to pontificate about that, but Alec again swoops in to tell us the ferritin is very low. So this is in fact iron deficiency. Is that a mystery? Probably not, because the patient has a history of atrophic gastritis. And so I think the question to wonder, now that we've proven that this diagnosis that she has in her past is still ongoing, is again, is it syndromic, and is it part of a pernicious anemia complex, which would have implications that extend beyond the belly? I would just say, as a general teaching point, the ability of the labs to help you adjust your pretest probability and post-test probability of Cushing's is limited. In patients, though, with ectopic Cushing's, they have such prominent, severe, strong steroid secretion that they tend to have two things that are elevated. Their white count can be elevated, and because of the effects of a whopping dose of steroids on the aldosterone receptor, their bicarb can be elevated. So neither here is the bicarb elevated or the white count elevated. And so I think the probability of ectopic Cushing's decreases when those two things are not present. And one deficiency is also helpful, and that deficiency is of potassium, again, reflecting the effects of aldosterone. And so here, the fact that the white count is normal, the potassium is normal, and the bicarb is not high, all are gentle arguments against ectopic Cushing's. The one lab value that can help reinforce the notion of the presence of steroids, is the eosinopenia here, which really reinforces Prof. Rez's observation that this person has a lot of cortisol on board. Guys, when we start to develop momentum and start to develop hypotheses, we all have put our blinders on and we start to ignore pertinent negatives. There are two massive pertinent negatives here for the diagnosis of steroid excess. You guys know what those pertinent negatives are? Put them in the chat, say them out loud. What's a massive pertinent negative here? A gaping hole. It's so big, it's bigger than Prof. Rez's smile. Look at that blood pressure. Is this a Cushing's blood pressure? Look at that glucose. Is that a Cushing's glucose? These are massive holes. So what do we do with them? If you find in a patient with concern for Cushing syndrome that they have some features of adrenal insufficiency, lowish blood pressure, much lower than you would expect, lowish glucose, much lower than you'd expect, you have to wonder about the possibility of exogenous steroid use. Why? The adrenal gland is so finely controlled that if the patient starts to take their own steroids, they now control how much adrenal hormone they are giving themselves. And the adrenal gland goes to hibernation, like the grizzly bears I was watching yesterday on a wonderful YouTube documentary we can talk about later. So if this patient is in fact controlling how much adrenal hormone she has by how much she exposes herself to it, or steroid hormone, then she can hit highs and lows. If you take a whopping amount of steroid cream for your osteoarthritis, apply it, or take pills for it, and then because you don't feel well, you stop taking it, what's your glucose and your blood pressure going to be? Low. So the combination of adrenal excess and adrenal insufficiency further reinforces the probability of exogenous steroid use, which is by far and away the most common cause of Cushing's anyway. So I'd be really, really worried about that in this patient. And my advice to all of you is to remember that if a patient looks Cushingoid, they could have adrenal insufficiency if they stop taking their exogenous steroid, or if they have apoplexy of their tumor or their adrenal gland. So we still have to keep our eye open for adrenal insufficiency for this patient. And maybe less commonly so because of the atrophic gastritis. She may have Cushing's, but hey, she's got B12 deficiency, iron deficiency. Could that be pernicious anemia? Is that affecting her adrenal gland in some way, shape, or form? So my mind with this data, Prof. Rez, I'd be really curious what happened with yours is, whoa, she's a setup for adrenal insufficiency based on the atrophic gastritis, the low B12 and low iron, and her glucose is not as high as I thought a patient with Cushing's would be, and her blood pressure isn't as high as I thought it would be. So I'm now entered a zone of caution. Before the labs, it's like, boom, Cushing's, locked in. And now I'm retreating a little bit because I think that in real life, it's very easy to now make a mistake because things are not lining up. So the only progress I have made is to recognize the things that are arguing against what I was initially locked in on, and to be open to the possibility of adrenal insufficiency. And if this patient were to get sick, even though she has striae, moon facies, and a fullness in her fat pad, I would give her steroids. And what crossed your mind, Prof? Any thoughts about that? Or
Bro, that's why we call you the mathematician. That is so great. Because even if this case ends up not being exogenous steroids, it's so important to even think about that possibility for good reasons. The blood pressure, the glucose, because this patient can acutely decompensate and can acutely have cardiovascular collapse. So I'm really glad you mentioned that. Like, it's an epic pearl. And I'm very excited to see what data we get next. But really. So Robbie, I guess you're sending, in addition to getting more of a history, hey, are you taking any supplements, any steroid injections in the knee, et cetera, anything that may expose her to steroids? You're sending an AM cortisol in this patient to further work up the possibility that she does have adrenal insufficiency. She may also have Cushing's on top of that, or more likely, the way you unify, she gets excess steroids, gets atrophy of the adrenal gland, stops taking that, and now comes in from the excess steroids having Cushing's, but then the hypotension from the adrenal insufficiency because she's not using that adrenal gland. I love it, man. Alec, I think his math is adding up.
It never doesn't, right? But amazing discussion.
Oh my gosh, it definitely doesn't at times. I have proof on it on our Epis podcast. And then, honestly, like today, I have to just share a quick story with the audience. It was, oh my gosh. So we were on hole number 7, and I set up for my second shot, Robbie. I hit it probably like 30 yards. I'm not even joking. It hit a tree and then bounced back towards us, and it went backwards 10 yards, meaning it traveled 40 yards, 30 forward, even more, and then traveled behind. And then my dad and I both were on the floor laughing. And that's sort of the feeling I get when you mess up adding like on the podcast episodes. But anyways, to you, Alec, my friend.
Love it. Okay, so some additional labs here. For the vitamin B12 deficiency, an intrinsic factor antibody was done and was negative. An antiparietal cell antibody was positive at a level of 102, with the lower limit of normal being 20 in our lab. She was also complaining about the small joint pain as well, so we investigated that a little bit further. An ANA was 1 to 80 with a speckled and nucleated pattern. Complement was within normal limits. And rheumatoid factor, CCP, double-stranded DNA, Smith, RNP, all those antibodies were negative. And in regards to some additional testing, she did get a TSH, which was 5.93, upper limit of normal being 5.3 for our lab, so a little bit elevated. The free T4 was 0.4, and the lower limit of our lab being 0.6, so also low. And she got 8 a.m. cortisol, which was 2.6, lower limit of normal being 3 for our lab. Given her profound iron deficiency, she also got an EGD, which didn't show any ulceration or mass, though some atrophic appearing mucosa. And she had random biopsies of that showing chronic atrophic gastritis with intestinal metaplasia. H. pylori was negative. And yeah, I think I'll stop there.
Robbie, did you want me to tackle this?
please.
All right. Well, I think it's first important to understand a positive test doesn't necessarily mean a positive diagnosis. If you go and screen the entire population, a good portion of people, up to 20%, will have an ANA of 1 to 80. So what do I do with that ANA? I just dismiss it. It's positive, but it's not suggestive of any, it's not suggestive of lupus. With regard to the parietal cell antibody, I think our hypothesis of pernicious anemia is confirmed here with the parietal cell antibody being positive. Now, the AM cortisol that's less than 3 is diagnostic of adrenal insufficiency. If this patient didn't have the moon facies, the striae, and the fat pad that Alec described on physical exam, I would say that this is very consistent with autoimmune polyglandular syndrome. But because the patient has that moon phase, like there's something that caused that moon phases. So I think Rabih's hypothesis is spot on here, meaning this patient probably had excess cortisol, then stop taking that cortisol. We still don't know where that excess came from, whether it was in the form of injection of the knees because she has osteoarthritis or she was taking it for some other reason, then stopped it and now has an atrophic adrenal gland as opposed to autoimmune adrenalitis that goes with the pernicious anemia, the vitiligo, the diabetes, and the autoimmune polyglandular syndrome. But there's going to be a really simple way to test this hypothesis, and that's sending an ACTH. Because remember, if you have autoimmune destruction of the adrenal cortex and you have adrenal insufficiency because of that, the pituitary is intact. It's going to shoot ACTH through the roof. So our next step is to ask, hey, what is that ACTH? And if our hypothesis is correct, that is exogenous steroids, that ACTH is also, because it's going to suppress the entire axis, not just the adrenal gland. And so I think, I know you commented on the TSH and the free 3-4, those look fine to me. She's in the hospital, whatever. I think the next test is send the ACTH. And I think if that is low, then it really strengthens that hypothesis of exogenous steroids. And then it's going to be, where did that exogenous steroids come from? And they can come in a lot of different forms. And I think you only have to be cautious because remember, if that ACTH is low and that cortisol is low, then you have to worry, is there a central process? Is there something in the pituitary that's causing this? And that's why sending all those hormones, be it the LH, the FSH, and the prolactin, are helpful because that can add further support if you have abnormalities in that and those hormones, because a structural lesion is not going to be specific to just one endocrine axis. It's going to be uniform. And that's a diagnosis that we can't miss. But honestly, I think, how can you have moon facies, striae, and fat pad distribute without excess cortisol? So Rabih, where I am is just, I think the next test is an ACTH and further history to exogenous steroids. And your pickup was so good, man, on the blood pressure. This is a phenomenal job.
Yeah, it's really hard, Prof. Rez, when you're getting momentum for a hypothesis to acknowledge the pertinent negatives. And, you know, having, as you said, I've been wrong many times. And when you fall flat on your face and you make that mistake, you learn it over and over again and not learn it permanently. I'm definitely going to ignore a pertinent negative in the future. I have no doubt about that. But I think, you know, one question just to say out loud is that I got answered recently based on a case at UCSF Morning Report, where if you are taking exogenous steroid and then you measure cortisol and it's low, how could that be? I think the simple answer is that you stop taking your exogenous steroid and now your cortisol is low because you don't have any anymore. The other answer is a really interesting one. It's worth everybody knowing, which is taking dexamethasone. So we remember what you guys, we use the dexamethasone suppression test to measure to see if somebody has excessive cortisol. And so we give them dexamethasone and then we measure their cortisol the next day. And if their cortisol is suppressed, we say, great, you don't have excessive cortisol. But how could their cortisol be suppressed if we just gave them dexamethasone? Doesn't it measure dexamethasone? And the answer is no, it doesn't. The only reason we use dexamethasone and not another steroid to suppress the excess is because dexamethasone is not picked up by the cortisol assay. So a potential mechanism or a potential way to clinch the diagnosis here is, as you said, ACTH, and also to consider getting a dexamethasone level specifically. Because if this patient is using a product that contains dexamethasone, it will not show up on the cortisol screen, but will show up in the dexamethasone screen. So to summarize, the cortisol assay does not pick up dexamethasone. We use that to our advantage when we use dexamethasone to try to suppress somebody's cortisol and measure their cortisol, because the cortisol that we measure will not include the dexamethasone we gave the patient. The corollary of that, if patients are taking dexamethasone and are resulting in Cushing's, their cortisol, when you try to measure their cortisol to see if it's high, it won't be, because you won't measure dexamethasone. So another strategy here is to get the ACTH and to get a dexamethasone level. And I am so grateful for Rob Weber, who joins us here on VMR not infrequently, who taught me this really cool pearl and allowed them to diagnose exogenous Cushing's in a very tricky case. So it stuck with me forever.
Dude,
Yeah.
you know what I love about that hypothesis is just this eosinopenia is bothering me a little bit. Like if
Yeah.
you're completely deficient of cortisol,
Right.
I would expect some degree of eosinophilia, but
Agreed. Really cool case. Yeah, I'm curious how this settles. It's definitely not a done deal, Prof. Rez. I completely agree. What you got next,
Amazing
Alec?
thoughts and pearls. Yeah. So for some additional testing, a prolactin was done. It was 32, upper limit of normal being 26 for our lab. The FSH, LH, and IGF-1 were all within normal limits. For the high TSH and low free T4, she did have a TPO antibody, which was very positive at 115, upper limit of normal being 34 for our lab. And she had an ACTH level, which was 1.5, the lower limit being 7 for our lab, so very low. She did have an MRI brain pituitary protocol, which was completely normal. And then she did undergo an ACTH stimulation test, which the cortisol prior to admission of the ACTH was 3, at 30 minutes was 9, and at 60 was 11. So it was a failed stimulation test. And that's the end of this aliquot, and the next aliquot will reveal the final diagnosis.
Yeah, I think Alec, we've just proved, I can imagine you guys the double A's, it's amazing. I think we've proven that this patient is adrenally insufficient, and I think that we've proven that the adrenal insufficiency is not at the level of the adrenal glands. This is a adrenal insufficiency either in the pituitary or the hypothalamus. And the fact that the pituitary imaging is normal doesn't prove, but very suggests that the adrenal insufficiency is at the level of the hypothalamus. And I think in the context of the exam that you pointed out is very concerning for exogenous steroid use. So I'd be pretty worried about that now. And I think the next step, honestly, is history to take it back full circle. That's what I was honestly alluding to with the residents in El Salvador. I grew up in a community in Pakistan where if you sneezed wrong, you would get levofloxacin, Augmentin, and some steroids. And so I know that these things are culturally based. I don't know the local culture at all, but I know to be open to learning that about this person. And so that's probably where my mind would go. But I think a dexamethasone level, it's not something I knew about until a few months ago, so it may not be something that's done universally, but that would be a curiosity I would have for sure. Prof. Rez, where's your money at? The $120 you've earned in this case.
I'm investing it all in you, my friend.
Okay, amazing. So we did take some iterative history, and the patient had been taking a supplement from El Salvador, but she was actually able to buy it here in the United States. It was called Archer King, and the supplement had actually undergone a recall from the FDA in 2022 because it had diclofenac and dexamethasone that wasn't actually mentioned on the active ingredients. So, on consultation with everybody and reviewing the case, we felt that she had, central adrenal sufficiency, and then sort of cortisol excess and related to the supplement. And then, for her small joint pains, we couldn't really piece that together. And actually, my team decided to send a parvovirus, B19, and her IgM was very, very elevated. So we think that actually her anemia was also a little bit worse in general because she had some sort of aplastic anemia, or just some anemia related to that as well. And that was explaining her small joint pains, which ultimately got better and wasn't ultimately related to the final diagnosis, but was a really rich and interesting case. And I asked endocrine about the dexamethasone level, and they told me not to bother. So that's why we didn't send it.
I'll just jump in to say that that this was like an absolutely unreal case, and I think my favorite part, honestly, was the dissection of the exam to come to a conclusion, and the dissection of labs to come to the exact opposite conclusion, and then to try to put them together. It was so much fun. I really appreciate you, Alec, and you really appreciate you, Prof. Rez. I think should give you another $60 for that beautiful smile, getting you richer and richer as you go. But the reason I jumped in is I apologize. I'm actually on the job right now, and it got fairly busy. So I will hand the mic to you, Prof. Rez, to bamboozle the rest of us for the remainder of the hour, and I'll have to bounce. I just made you host, so enjoy the rest of the
Thank you so much, Robbie. Good luck, my friend. So I also just want to echo what Robbie said, Alec. Thank you for presenting this case. And if I did my own cognitive autopsy, I think, you know, rather than saying Cushing's syndrome, just starting with excess cortisol and then going down the algorithm is maybe a way to prevent premature closure or diagnostic momentum on Cushing's syndrome, which is related to pituitary adenoma releasing ACTH. So that is my main takeaway is like, yes, that exam is slam dunk excess cortisol, but then the question becomes, where is that excess cortisol coming from? And I think that pro that Robbie shared with the blood pressure was a really cool one to link it. And then the glucose being normal to really suggest that it's more exogenous. With that being said, I'd love to let you give a last few words, Alec, before we pass the mic to Khashayar to close the session.
Yeah, thanks so much. It was a really educational case, and actually we were able to get the supplement fairly quickly. This is actually a supplement that has been used by some of our patients. We take a lot of care of patients, a lot of patients from Mexico and Central America, and so we're a little bit more in tune to ask about this. And you know, Zavin actually had a case of this drug causing disseminated strongyloides in a patient that had cortisol excess, and so we were a little bit more in tune to ask about it. And then Austin, like as a primary doctor, he always sort of like hits into me about asking about supplements, so I try to do a good job of doing that. And you know, she had a really underlying autoimmune propensity with her, you know, atrophic gastritis and her pernicious anemia, and then she actually ended up getting diagnosed with primary hypothyroidism as well during this time. So I think that's why we ended up down a little bit of rabbit hole as far as the autoimmune workup as well. But it was just a really great educational case. It was a great way to take my students on, you know, in residence to go examine her. She just had a lot of really interesting clinical findings. She was the nicest lady. So I'm glad she was overall doing better. We were able to get an answer for her. And, you know, I wonder if the parvovirus just made her anemic enough to want to come in. She was very focused on her work, and I'm glad that she did. And so we were able to figure this out. And just a lot of learning. And you guys, as always, dissected it in a way where I just learned even more. So really enjoyed it. And Kasha, I'm really looking forward to your teaching points.
Thank you so much for the great case and the great discussion. Okay, let's just start with the teaching point. At first, our initial approach was to frame the patient and make sense of what we have. We have a constellation of symptoms that we have to start putting together to solve the puzzle. We have alopecia, we have constipation, we have amenorrhea, and we have shortness of breath plus weight gain. Alopecia is rare enough to think about it as something that can answer our case. Whatever answers the alopecia will probably answer our case. The most common cause of it usually is excess in androgens, because the DHT-sensitive hair cells fall out in a horseshoe pattern, and the hair cells in the back are resistant to DHT, so they don't fall out. We got to put this piece of information here. Then we have the constipation. What do we do with it? It's fairly common, but we need to know when to worry about it. If it's sudden onset, if it's refractory to treatment, if it's associated with red flags, we need to think about secondary causes and work it up further than usual. Then we have the amenorrhea. We can't frame it as secondary versus primary. This case is more likely secondary because primary causes are usually lifelong causes, and we can follow the history a lot more back. In secondary causes, we have to frame it as a deficiency in estrogen versus progesterone. Progesterone is much more common, and again, is usually caused by excessive androgens. Put this with the alopecia together. Now we have to answer perhaps the most concerning initial symptom, the shortness of breath, and fever, and weight gain. Usually, if you see shortness of breath and weight gain, you go heart failure, heart failure, heart failure. But in this case, your patient is feeling well, you don't see any swelling. So you gotta kind of feel a little bit better. Then you see fever and shortness of breath. Again, usually if you see this, you go pneumonia until proven otherwise. But all of the symptoms together right now, it doesn't give a picture of any of them together. So we can feel a little bit better. Attribute the symptoms that we are seeing with shortness of breath and the weight gain to the conditioning of the patient, perhaps because they gained weight due to some other cause, and then work the patient up further. So it seems right now that we have a profile of androgen excess here. 2 of the 4 main symptoms that we have are explained by it, but we have to go forward. Here, before we go forward, I have to remind everyone to pay attention to where the patient comes from. It's not just that they bring their infections with them. There are cultural norms, there are behavioral patterns, there are malignancy risk profiles. There are, especially what we saw in this case, drugs that they bring with themselves. Now, as we examine the patient, we see more and more and more of Cushingoid symptoms, moon phases, purple hysteria, weight gain, enlarged fat pad, etc., etc. So we need to frame this. How do we frame the Cushing? We frame it as exogenous versus endogenous. The exogenous causes are much more common than you might think. I've seen it in meth addicts who used it to gain weight and hide their symptoms. I've seen it in herbal weight gain medications. I've seen it almost everywhere. It's much more common than we like to think about it, and endogenous causes. When we're thinking about endogenous causes, we have to frame it as the hypothalamic axis versus ectopic Cushing, something somewhere else in the body producing the excess androgens, the excess cortisol. Here, the visual field anomaly perhaps can point us to something relative to the hypothalamus itself because of the anatomy there. The optic chiasm is closed there. In cases of ectopic Cushing, we may see a white BC elevation, bar cap elevation, and because ectopic Cushing usually presents with extremely high levels of cortisol production. So we got to keep that in mind when we want to differentiate the endogenous causes. Here, though, we got a little bit of tunnel vision. The Cushingoid symptoms are so prominent that we may forget that the glucose and the blood pressure are not what we expect from a Cushingoid patient. Are they experiencing adrenal insufficiency? Further workup showed that yes, we have an additional flavor of autoimmunity. We have vitiligo, we have pernicious anemia, all of them coming together and bringing us not just a picture of adrenal insufficiency, but a picture of Hashimoto hypothyroidism, which can complicate our causes. So putting all of it together, we see a patient who is presenting with symptoms that are perhaps both sides of a spectrum. A Cushingoid disease caused by an exogenous cortisol and adrenal insufficiency. One interesting final fact here was that we were not picking up the initial exogenous cortisol here. 2 reasons may be the case here. One is that when we are dealing with exogenous glucocorticoids, patients experience highs and lows because they are not consistent in taking the exogenous glucocorticoid, and dexamethasone is something that is not picked up by the cortisol acids, which is why we use it to test for cortisol levels. But it can be an exogenous cause in for patients. Thank you, everyone.
Khashayar John, soon I have to give my position to you. It's going to be Rabi and Khashayar on Friday VMRs. That was a terrific teaching. I want to give a shout out to VJ for scribing and Alec for bringing a wonderful case. And if anyone has any final comments to make, please unmute yourself. Harry, it was really nice to see you, my friend. Really, it's been many months. So glad to see you.
It was great to be here, and I hope I can make more of these in the future. I just need to get sick every Friday and stay out of work, I guess. Yeah, I would say this was fantastic and well presented, great solve. And I just encourage the learners in the audience to also think about not just what we've already learned here today, but to really consolidate knowledge by grabbing something you're curious about or that you're like, oh, geez, I never would have thought of this or that. For me, it was autoimmune polyglandular syndromes. I haven't thought about them in forever. So if I want to really expand my learning here, I'm going to go and read about them for a little bit after this to expand my illness scripts over time.
Let's leave it with that. Take care, everyone. Harry, feel better. Bye.